Welcome to episode 2 of The Other Side of Lucy Letby, a podcast that looks at the medical and scientific evidence used against Letby at her trial. I think it's important, first of all, to look at the mother's statement, BBS and BBB's mother's statement that was given to the court. And this statement was dated from 2017, so it's 2 years after the tragic death of her baby. She confirmed that she'd been diagnosed before pregnancy with a blood disorder and had been given medication to treat it. She discovered she was pregnant, and it was decided the blood condition would be monitored and managed throughout. It was planned for the babies to be delivered at a medical centre outside of Chester at full term. The mother was admitted to the Countess at Chester Hospital and was very upset as there had been medical issues diagnosed, and she had only been a week away from moving to the area where the specialist outside of Chester would have delivered the babies. The mother had an emergency cesarean section as her blood pressure levels were high and the twins were delivered. So we can see that the whole circumstances of this were just tragic for this mother. Her babies were born in the wrong place at the wrong time, when there was an extensive plan in place by a caring group of consultants elsewhere who were familiar with this condition that the mother had. So the condition that the mother had is a condition called antiphospholipid syndrome. Antiphospholipid syndrome is an autoimmune disease, and an autoimmune disease is simply when our body makes antibodies against ourselves in different parts of ourselves. We don't exactly know why they happen in every case, and it is a treatable disease. APS. A phospholipid's purpose is to allow fatty acids to dissolve in water, and so they're found all over the body. The particular area that is affected by APS, the antiphospholipid syndrome, is the clotting of the blood. So these patients are prone to any clots, lung clots, heart attacks, different things like that. So they are at risk from this disease. But also pregnancies in particular at a high risk from this disease. And many pregnancies don't reach term. So there's a very high incidence of preterm deliveries with antiphospholipid syndrome, and that should have been anticipated, and it should have been, and it no doubt was planned for, but unfortunately the mother ended up in the Countess of Chester Hospital. And the mother had a twin pregnancy, and the twin pregnancy is at least double the problem. Likely there's intrauterine growth restriction, and then we have the preeclampsia, and we have to use general anaesthetic, and that is a risk for the babies as well. So we have a very unfortunate situation here right from the get-go. Multiple risks, a very high-risk pregnancy. The consultant that delivered the baby, in my opinion, they didn't have any choice. For whatever reason, the mother ended up in the Countess of Chester Hospital. She obviously lived locally to it because she was moving, but she ends up, it's not clear from the record how long she was admitted to the hospital. That's one thing that, again, is not clear. But the consultant who did the operation on her only seen her on the 7th of June, which was the day that she had the operation. But the consultant really didn't have any choice. It seemed as if this lady's blood pressure had gone up very high, which was a major risk to her and the babies, and that he says that the coagulation of the mother was affected as well. So again, major risk. So this is a type of situation that you would really need to have the baby born in a level 3 unit. You would not have these two babies born in a local neonatal unit, not at all. But I think it's really interesting to go to the prosecution opening statement about BBA. So BBA, a boy, was born premature in June 2015, the younger of a twin child, BBB. Medical records for BBA's birth are shown to the jury, including the names of which medical staff were present at the birth and the condition of BBA, plus medical records. BBA was in good condition at birth and taken to the neonatal unit. 13 hours later, he was breathing in air without the requirement of extra medically administered oxygen. And that is the opening statement of a prosecution for the murder of a preterm neonate. It is as clear as day that BBA was not born in a good condition. Indeed, BBA was born in a very bad condition. And 13 hours later saying that the baby was breathing in air without the requirement of extra medically administered oxygen, again, is incredibly misleading. The baby was already on ventilation 13 hours later. So the baby was breathing with the assistance of a CPAP machine, and without the CPAP machine would not have been breathing probably sufficiently to stay alive. And the fact that there was no medically administered oxygen, as we will see, was likely a mistake. There were indications that BBA needed oxygen but didn't get it. So we'll look first of all at the ridiculous things now that the medical experts say, and this is just summed up on the Total Life website. The case was referred to the coroner and the cause of BBA's death was unascertained at the time. It was a natural cause of death, and there was an inquest that said it was a natural cause of death. The fact that it's unascertained is not unusual in preterm babies because they have such complex physiology that it's not always possible to say that, what exactly caused the death. I mean, there could be a lot of theories and thoughts and stuff, but not everything shows, and BBA unfortunately dies within 24 hours of birth, so it's going to be very difficult. So the unascertained doesn't mean anything, really, in terms of evidence. But medical expert Dr. Dowie Evans suggested that BBA's collapse was consistent with a deliberate injection of air or something else into BBA's circulation a minute or two prior to deterioration. Mr. Johnson, the prosecutor, tells the court, and only Letby was present. Now, this is what is reported in the paper. But I have no idea why Evans said that it was consistent with a deliberate injection of air, and then goes, or something else. Because by saying that, he's saying, I don't know what caused this collapse. It was either air or something else. Like, what else is he talking about? Was any other substance found in the baby? No. Was air found in the baby? No. I don't know where he got this from. Another medical expert said that it was not some natural disease process. Well, I beg to differ. But a dose of air deliberately administered. I beg to differ. An independent pathologist described the cause of death as unascertained, in that there was nothing in the autopsy that pointed to why child A had died. But the cause was most likely exogenous air administration through the long line, or UVC. So again, there's no certainty over this. It's a guess that the cause of death is unascertained. But even if there was exogenous air administration through a long line or UVC, it's impossible to say, unless you've seen Letby do it, that air arrived in the baby's system by Letby's hand. The air can go through a long line or UVC without any assistance. It's called iatrogenic, an injury caused by a medical procedure. And it is the common reason why this happens. Air can go into the system through ventilation. Air can go into the system through CPR. But it's just air. So you cannot tell, even if you find air or evidence of air in the baby post-mortem, you cannot tell where the air came from. No one's seen Letby do it. You cannot separate that Letby air, which they attempt to do in the golden thread, from air that got into the system by any other means. So it's really important to outline just how weak all this stuff is right from the get-go. We'll look now at the description of the baby's birth, and we'll show just how far away it is from being a stable baby at birth. So the baby is born by emergency cesarean section under general anaesthetic around about 8 to 8:30 p.m. on the 7th of June. From the record, no evidence that there was a consultant neonatologist present at the birth, despite the evidence from the obstetrician that this pregnancy was high risk, and it very much was high risk. We don't know what pharmaceuticals were used to treat the high blood pressure. We don't know what was used in the general anaesthetic, and did they have any side effects on the neonates. We don't know anything of that. But we do know that both babies required resuscitation at birth. So these are babies that are born in good condition, but they require resuscitation at birth. They're 31 weeks gestation, and they're born to the mother with APS. 2 people were present to care for these high-risk neonates. So that was a junior doctor, a junior registrar, and a nurse, a senior neonatal nurse. 1 doctor for 2 babies and 1 nurse for 2 babies is just nowhere near enough to deal with this situation like this. In anticipating the high risk and the likelihood of respiratory distress syndrome and all the other problems that come with antiphospholipid syndrome at a much higher rate than people who don't have antiphospholipid syndrome, there should have been at least 4 people present at the birth, but there wasn't. There was 2. So we have an agreed statement from the doctor that was present. We don't even have the doctor there. The most important part of baby A's care and life was the birth, and yet we don't have the doctor there to question. So in a statement, the doctor recalls the care that she provided to baby A in the minutes after his birth, including breathing support by a neopuff device. That's a little handheld thing to inflate the lungs and get the required heart rate, and that's fine. You would often have to do that with neonates, with preterm neonates, to get the lungs going. But then she goes on that further ventilation support was given on child with a neopuff for a short time to reduce pauses between breathing. So obviously the rescue breaths that the baby was given weren't sufficient to get the heart rate going and to get the breathing going. She was recorded as having very good oxygen levels. It doesn't say when these oxygen levels were done, but so using the neopuff device was reduced. So again, we don't know how long that carried on. And then the doctor says that the baby was fully breathing by himself, and that administering breathing support was not unexpected for a preterm baby. Well, that's absolutely right. But the statement goes on, the decision was then taken to transfer him to a neonatal unit, which again is very reasonable. And the doctor recalls showing the baby to the family en route to the unit. What we don't know was the baby given any surfactant? Was the mother given any antenatal steroids? Again, none of this is explored. And these are medicines that are essential really in these situations to mitigate any risk factors. The doctor goes on to say she recalls chest compressions being seen on baby B, which she interpreted as a bad sign. And it was difficult to know which baby to assist. This is what the doctor says, as child A was still not stable. So another doctor entered, and the first doctor said that the new doctor should look after baby B. And the first doctor had no further care for baby B that night. So we have this situation where the rescue beds were not sufficient and the baby needed intensive care and resuscitation immediately, but there was only 2 people present for the birth of twins. This is appalling. The agreed evidence statement from the other doctor that came in, it's at 11:50 p.m. So that's nearly 4 hours, 3 hours, 4 hours, whatever, on June 7th, after baby A was born. And his observation is baby A appeared well and clinically stable on CPAP. So within 4 hours, the baby is on CPAP. Well, a baby who's ventilated within 4 hours is a red flag for sepsis. Means that you assume that this baby has sepsis. We also see that the admission time for the baby was at 2:41 a.m. on June the 8th. So we have a 6-hour gap where we don't know where the baby was. What the nurse had to say about the delivery was she recalls that baby B, the second twin, required assistance at birth and that support was given to her. She explains that more support was required for this baby than for baby A. By that, I presume she means the support was given to her by the doctor. I don't know, because the doctor's not there to question. But if that's the case, then that's a triage decision. That's not a clinical decision. The decision was that baby B needed more help. That does not mean that baby A did not need the same assistance. And I wonder what happened here. Did baby B get more help and baby A didn't get more help? And this nurse goes on and she confirms that baby A had a clinical indication for suspected sepsis on June 7th at 10 p.m. So that's within 2 hours of birth. The baby is diagnosed clinically as having sepsis. Now, we're not told why, but I've already said that being on ventilation is one of the red flags for sepsis. So how far are we really, in truth, from a baby born in good condition that the prosecutor said? We are so far away from it. We are in absolute catastrophe area already because there's been no smooth transition from the womb to the room. The baby is needing intensive care in a neonatal unit, and there's only 2 people present at the birth, and we're now waiting 6 hours to have the baby admitted into the neonatal unit. And the nurse, interestingly, also says that the blood gas machine was on the unit in the next room. So this is the machine that they would have used, the little capillary test for measuring oxygen in the baby's blood, and acid and lactates and different things in the baby's blood. But really, for a baby of this high risk and this very low gestation and weight, there should have been an arterial line, an umbilical arterial line put in, because it's only the umbilical arterial line that will tell you exactly what the blood oxygen is. The capillary line will not tell you accurately what that is. So the following day, things don't get any better. And it starts off with a band 6 nurse who comes on at 7:30 on June the 8th. So baby is about 12 hours old. And the first thing that she says is that the respiratory rate was slightly raised at times. And the nurse says that this was not unusual. Well, it may not be unusual, but it's a sign that the baby is in distress. So the breathing centre in the brain is telling the baby, you're not getting enough oxygen, or you've got too much CO2, you need to breathe faster. That's what that is saying. But it's minimised. It's not unusual. Baby's stable. And she goes, one thing that he didn't have was fluids for a couple of hours because of the line issues. Right, the cannula had tissued at some point during the shift. The vein had gone and wasn't suitable for a cannula to be used there. So we're not even told who put in the cannula, what kind of cannula it was. It was likely a little butterfly, something like that you would use at the outset, but it's not a central line. And we're now 12 hours in to the care of this baby. And the baby's on CPAP, it's got a diagnosis of sepsis, and now we have no fluids running. And we don't know really for how long. Now, the nurse goes on to say that the baby would not have had fluids for a couple of hours, but she's not really sure. And what she's really failing to appreciate as well is that this baby has had 12 hours of what's known as insensible water loss. So the baby is losing water through the skin, through breathing. It's losing a huge amount of water, and you cannot have the baby in a situation like that, a baby that is particularly sick in this way. I mean, a baby will need at least 60, 80 mils per kilogram of water a day. It's going to need sodium. We don't know any of that. They haven't measured any of that, or they're not given any of that in their statements, which is really, really incredible. So you have to say that a failure to examine the fluid charts, the body weight, the change of body weight, the electrolytes, all of that for baby A was a serious failing for the defence. And there should have been another doctor there to say why it was important, not only important, why it was critical to have all of these things in play, and they were not in play. We get to the point where Mr. Myers, who's the defence barrister, is cross-examining this nurse. He says that the nurse would have been looking after an intensive care unit baby and another baby that required a lot of care, and that falls outside the guidelines. This is the problem that was highlighted by Royal College Paediatricians' report. There wasn't enough staff to deal with a baby or a pregnancy like this. The nurse has shown a chart, and it documents the insertion of an umbilical venous catheter for the child. The nurse can't remember the two attempts to insert the umbilical venous catheter, but she sees that they were made in her notes. The notes weren't written until 7:05 p.m. And the umbilical venous catheter's in the wrong position, reinserted in the wrong position again, cannula tissued, and the doctors are busy in Ward 30, but they're aware that no fluids have been running for a couple of hours. So this is incredible. And the intensive care chart showing cannula tissued at 4 p.m, but the nurse explains that she might have written cannula tissued retrospectively, so it could have been before 4 p.m. when it was noted. So she doesn't have an idea. There's no one here has any idea how long fluids have not been gone into the baby. And more importantly, they have not been putting glucose into the baby. So a preterm baby at 31 weeks will have maybe 2 or 3 hours of glucose stores in the body. And it has very little physiology to make new glucose from the body and replace the only energy source that the baby has. So this is disastrous care. A baby with sepsis, a baby on CPAP, not on any oxygen, that doesn't have a central line. They don't know what time the fluids went. This is what the prosecution has described as a baby born in good condition and breathing it by itself in our 13 hours later. It really, really is awful stuff for a preterm neonate to be in this situation. And I'm sure that the mother is not really totally aware of all of this happening. We get into Mr. Myers asking again about the observation chart and says the chart shows that the respiratory rate is elevating. And it's shown to the court that it's elevating throughout the day. Yes, a little, replies the nurse. And then we get the stunning information from the blood gases. So this little blood gas capillary machine that measures the blood gas, we find that at 12:30 a.m., so that's 4 hours after the baby was born, we have the first of the readings of lactate. The lactate is 1.6. Then at 6:37 a.m., we have a second reading of 2.6. So the lactate is now climbing. And at 2 p.m., which is hours later, it's up at 2.7. Mr. Myers said the latter two readings are outside the desired area, and no other records are given. So that means that this baby with sepsis and on a ventilator has elevating lactates, and they're ceased being measured at 2 p.m. That's 6 hours before the collapse at 8 p.m. So we don't know. No one knows what the lactate level was at the time of death for baby A, because they ceased measuring them at 2 o'clock. And why did they cease measuring them at 2 o'clock? Because we have the nurse that's supposed to be doing one-to-one care for this baby is actually doing 1-to-2 care. And we get into this whole ridiculous argument where the nurse is arguing about whether the baby was intensive care, baby was not intensive care. The baby was intensive care and needed to have central lines in immediately after birth. And all of this didn't happen. Now, you have to remember, Letby isn't even on the scene yet. She is nowhere near the situation where this baby is in dire straits. This baby was sick from the moment it was born, and it was not born in good condition, and Letby is nowhere near the scene. How was the prosecution able to depict this birth in the way that he did? Now, the reason that we need to worry about the lactates, we'll do this kind of really quick. So the only source of energy that humans have is oxygenating glucose. And we do that in 2 stages. The first stage is called a Cori cycle. So that's where glucose and oxygen get turned into lactate. If there is insufficient oxygen, that lactate is returned to the liver and reconstituted back into glucose again. And this is then oxygenated again. And that cycle goes on and on. So that's called the lactate cycle. And that will produce 1 unit of energy for the baby. And the energy is produced in the cells that need the energy. So the body doesn't have any way of transmitting this energy from areas that need it less to areas that need it more. All the energy that is used in the body is used in the exact location that it's made. Now, if there's sufficient oxygen and the baby is not under stress and everything is working, that will go through what's called the Krebs cycle. So the glucose will move through 5 further stages of oxygenation, which will produce a total of 35 units of energy, or ATP. So 35 to 1. So this system, this biological system that can produce 35 units of energy is not producing 35 units of energy, or we can't be sure it is, because it doesn't have enough oxygen. And we don't know if it has enough oxygen because we've ceased doing the blood oxygen readings at 2 p.m. Now, there are other reasons why lactate can be high, but they're generally a measurement of hypoperfusion. That means that there's not enough oxygen circulating in the baby's body. So the baby, rather than being given just compressed air, probably should have been given oxygen. But what do we also see here? Where's the presence of the doctors? A junior doctor at 1 o'clock tried to put in the central line, couldn't do it, took advice from senior doctors, more senior doctors. We don't know who these more senior doctors were, because these people are not in court to be cross-examined, and didn't get the help. So this umbilical line was left in the baby in the wrong position, and nothing was done until another doctor came on the scene at 5 o'clock. And even then, nothing was done. So we have to see the lactates are rising up. We don't know how high they're going to get. But another sign of stress in a baby is failure to clear the lactates. So the fact that the lactates are going up, it doesn't necessarily mean that they have to be very high. If they're sustained high, above 2, it means there's likely not enough oxygen. Also, the lactates are adding to the acidity of the blood. So when you add to the acidity of the blood, the heart is not going to be as efficient when it's working. So every one of those heartbeats and heart rates that they're measuring are actually likely to be contractions of the heart that are not sufficient to move the oxygen around the system. So we have a catastrophe here. We do not have a baby born in good condition and a baby stable 13 hours later on oxygen. No, we have a catastrophe. I can't believe that a neonatologist who is given evidence for Letby would not have raised these issues as being very dangerous and very undesirable situation for this baby. The nurse is doing all that she can do. She's got 2 babies. She has to deal with them both. The system that Dr. Jairam was so angry with had indeed let down baby A, and the mother was obviously not told any of this, and Lucy Letby isn't even on the scene yet. So we'll finish this episode now, and in the next episode we'll look at what else happened in the care of baby A that was suboptimal, is the word they use. So we'll see you in the next episode.